Okay, thank you very much. Very nice to see you. I see it's one of these Wimbledon arenas that you look backwards and forwards. I'll try and keep kind of looking at you, but I may fail or get kind of some terrible neck complaint. I'm going to talk partly about the Berwick report, but also more generally about safety. I'm a psychologist by background. I'm a researcher, and I ran the Imperial Safety and Quality Group, as you say, which is partly about research and partly about implementation. And I've worked on safety, I suppose, for 20, 25 years and watched the evolution of it in this country from before there was any term patient safety right through to now, which is we are now gratifyingly a bit more concerned with it. And from the perspective of being a patient or having my family as members of patient, I'm very pleased about this. And it's particularly gratifying, I think, the last few years that boards have started to take a lot more personal interest in this. I don't mean that people individually weren't concerned about it, but it was perhaps not a big matter. And I do talk to boards quite a lot, and the choice of my topic today, which is, I hope, no, I think my title has been adjusted already. Oh, yes, it's Are We Safe? Are we safe seems a very pertinent question for you on a board. And when I talk to boards, as I'll explain a little bit more a bit later on, the question, are we safe, produces some very interesting discussions. And above all, and I include myself in this, complete confusion about what this means. And I think a lot of the talk today will be about trying to answer this question, or at least give us a way forward on what we mean by this. I was on the member of the Berwick panel, and we talked about a great many topics, and it was several months, very intense work with a number of subgroups. And I think it'd be too much to try and, if I talked about the entire report, I could skim through the whole thing, but frankly it would be very light. And I think you'd be better off reading the report if you want to read it. It's only 40 pages, it's very good stuff in it. So I'm going to pick the topic, are we safe, which is in some ways explicit in the report, in some recommendations and so on, that this is a critical question for boards particularly. But it's also threaded through in many ways. So this is what I'm going to pick up on. And in particular, the work we've done with the Health Foundation, who sponsor this work on the measurement and monitoring of safety, and explain to you what that's about. So I'm going to start with a little, in a sense, personal history, just for a few slides, but to give you some of the background of the last 10 years about why this, to illustrate some of the confusion about this, about what we're talking about, safety. And then we'll come through to the Berwick report and then onto the framework. And I suppose I would say that I know you've heard some discussion already this morning from a case history and a recent report about unreliability, the reliability of systems. It seems to me, talking to non-execs, and particularly people who come from, say, engineering or finance or a lot of manufacturing industries, it's just very hard to understand the levels of unreliability in healthcare and how that's a daily reality for staff to deal with this. So the idea of monitoring safety day to day and actually thinking about what's going on here and now is very critical, and it cannot be done by just looking at incidents and worrying about a few incidents that appear to be deviations from the norm. The norm is continual deviation, and that's the hard thing. That's the reality, and that's where one has to start in thinking about this. Now let me try and unpack that a bit as we go. Now firstly, the level of harm. I did a study with some colleagues about 10 years ago now in British hospitals, showing that with using record review, which is a systematic way of assessing whether patients are harmed or not, about 10% of patients are harmed, about half of these preventably. There's now, I should think, 20 national studies around the world with similar studies, 8 to 12%. So if you go back, you think how many admissions there are in your hospital or other, this is hospitals, I don't know, it's mental health, we don't have figures, and think about what that 10% means in people coming through the door, or next time you go to a ward. 20 people on the ward, then that's 2 of them are harmed and 1 certainly preventably. So that's the kind of basis we're talking about. And in response to this, we've set up, as you know, these huge reporting systems, which are very valuable and have their uses, but are frequently taken as being an index of harm. So this is our first area of confusion. And if you actually compare what happens in the reporting systems with a more systematic approach of record review, and this is a study that's done that, there's quite a number of others, you find that incident reporting systems detect only a fraction of this harm, only maybe 5%. And what's in the record is only a part of it, it's only a partial picture in itself. So the next thing to understand is that incident reporting systems are absolutely useless at detecting harm. They may be valuable for learning, but they don't pick up all the harm that are in the organizations in which you are in charge of. Now, that's our first sort of a confusion about safety and how we go about measuring it. I'm not pretending to have solved this problem completely, but I hope we can find a way forward. So the next thing is that one of the other studies we did recently, a few years ago, is to say, well, we've been working on safety for a long time. Can we say whether the NHS is any safer or not after, say, 10 years? And this is from the British Medical Journal again, all those papers were. And this is just an illustrative slide about the certain indicators you can get, like third-degree tears in obstetrics and certain kinds of infections, which you can pull out of the administrative data. And my colleague Paul Alien, who runs the Dr. Foster unit, did this, and he tracked them over 10 years. And they're all getting worse, all but one. Now, probably this is poor coding and so on, but it was not encouraging. But our overall conclusion from this paper was not that, yes, we were getting safer, or no, we weren't. It was in a way worse. We couldn't tell. And I think this is true of many, true much of the high-level NHS. We have some better data now, the safety thermometer, infections and things. We've got a bit more of a grasp on it. But being able to answer that sort of question, are we safer than last year or 5 years ago, and how are we going to tell, is very fundamental. And yet, and again, if you think about the other industries in which you've worked, you'd probably be able to answer that question. But above all, it's this question, in talking to boards and listening to people discuss this. And a lot of views are advanced. So some people say, well, you know, we haven't had a big incident for 3 months, so that's great, you know. I think already you're perhaps beginning to doubt whether that's very sensible. But is it culture? Is it the attitude of staff? Should we do culture surveys and see what they are? Do they report? What do they feel about the management? You know, is that going to tell us if we're safe? Is it compliance? If you're CQC, is it compliance with standards or the NHS litigation authority? Is that the sort of touchstone? Should we do record reviews and actually go through the notes and see whether people are harmed? That'd be quite a good one, I think. Or maybe, I've heard this is another very popular one, it's what the patient tell us. If the patients feel safe, that means the organisation is safe. Now, there's probably something important about that, but is it a complete story? Do we as patients know whether an organisation is safe? I don't think so. But the most interesting thing is how the conversation wanders around the table. And I'm including myself. I'm not sitting there being kind of clever about this. It's not that I have a click. Now, it's very hard then to deal with this very fundamental question. So I think if, in personal terms, this is in a way what motivated me more than ever to want to do this kind of work and try and think this through for myself, because although I've been involved in this a long time. So I'm going to tell you this story in a way. But let's just look also, picking this up. This theme, if you like, could come from Bristol, where Ian Kennedy made similar remarks about the need to measure safety and monitor what was going on. Then we have France, the organisation with the memory, which is still very much worth reading, of a report about 2000 that Liam Donaldson led, through Francis, more regulatory, and to the Berwick report, which is, I see as a complement to Robert Francis' report, not a rebuttal, but a complement, looking more at the improvement end rather than the regulation, very crudely. And these are the Berwick problems, some of them anyway. Priorities, clear warning signs not heeded, that's very fundamental to what we're talking about today. And the fact that patient safety problems are everywhere, and again, this is fundamental, and a variety of other things. And particularly the reports here, the Mastery of Quality and Safety Sciences, and also the need to develop learning. Now, I think the fundamental aspect of what they mean by learning is that you have to have some sort of information system if you are going to do effective learning. Because otherwise, if you don't know what's going on in the first place, it's very hard to generate the kind of improvements and the sustained culture of learning that the Berwick reports talked about. And obviously we have a lot of information in the hospitals and in other organisations, huge amounts of financial information, certain amount of quality information, and not very much in the safety sphere, as you might say. And in particular, most healthcare organisations have very little capacity. I don't know what it's like in your organisations, but I'll tell you a brief story. I went to one board and they sprang on me. They suddenly, a question, they said, well, you're a safety person. How can you help us use our safety information? What would you suggest? And I didn't quite know what to say, so I said, well, how many people have you got working on it, compared with the finance department? And everyone looked at the floor. I mean, they had one person and a dog working on the safety and quality information, and I don't know how many people in finance, which obviously they need. So it was a joke that they were taking it seriously. So simply having people on the ground who are actually analysing this stuff intelligently is just one of the simple things to ask about. I mean, some organisations have got teams of people and are doing fantastic stuff. Others got absolutely nobody and are trying to deal with this agenda. So that may be a good question to ask. So, coming to the report, the Health Foundation, the idea of doing this, and Jane Jones and Jonathan Bamber. And originally, I think they were thinking, as we were, more about what are the right metrics. You know, what are the measures and metrics? You have all these reports and stuff and RAG ratings. There's total confusion, it seems to me, when I'm looking at them, trying to understand them. Are there some that we should be particularly looking at or recommending? I think that was probably what we were thinking about. We've actually taken a slightly different track, which I will explain. So what we did was we looked at, we did a number of reviews to start with, and we looked at what the NHS was doing about safety. We did a review of what was known about the patient engagement, the patient perspective. We looked at what other industries were doing. Jane Carthy did a wonderful report on high-risk industries. How does the oil industry look at safety? And we also looked at the theorists and the researchers. What do the people who are thinking about safety say? They don't really recommend, as it turns out, specific measures, but they give us a sense about what was important that was much wider than one we started with. So then we have all this, and we did some case studies. We interviewed a lot of people at various levels in the organisation, some regulators and all sorts of people. And we started to do case studies, going to organisations and actually finding out what we did. And as we developed the whole thing, we started to get the frame, which I'm going to tell you about, and we'd take it into organisations and say, how does this seem to you? Does it work for you? And, you know, so it was a kind of back and forth. Now, this is something if you'll bear with me for a minute or two, I may seem to be doing something that's, you know, like slightly obsessionally academic, but I've come to think this is quite important with hindsight. We got to a point where we had these reports in safety in the NHS, other industries and so on. Now the question is then, you're writing a report and you've got to think, we've got to come up with something that's going to be useful to somebody. What's it going to be and what's it going to look like? If we go back to the are we safe conversations, we had the same set of choices. I mean, I was tempted, you know, to think initially, well, am I going to come up with the 10 measures? You know, people will say to you, mortality, HSMR. You know, that's the critical thing to keep your eye on. Or infections, or whatever. Are we going to come up with 10 measures, or whatever it is? Could have said it's culture. We could have gone in that direction, or whatever. There's lots of possibilities. Now, what we actually did was something rather different. And I think, as I say, with hindsight quite important, we came up with a series of questions. Now, if you think about the language of safety that you're fed from the Department of Health and others, it's about assurance and kind of tying it down. Now, I think actually that's a fantasy. And one of the first things to get away from is the idea that you can ever be sure that you're safe. Now, we know this in daily life. because the way we bring up children and all that is all about this constant awareness and constant questioning and, you know, looking around. But for some reason, the health service is operating in a very different model, which the more you think about it, the more strange it seems. So these are our questions we came up with, and it's not a random list. We had several variations, and there's a lot of background to this, which if you skim through the report, you'll see that there's a meaning to coming up with these particular ones. So one is, has care been safe in the past? This is harm. And this is not instant reporting, this is measures of harm. Actually having proper numbers, quantitative. Are systems reliable? I should say that this is reports downloadable, there's a summary downloadable, it's very easy to access, you know, and skim through. So just to let you know. Reliability, and I'll give you some examples of this in a minute. Safety is not the same as reliability, but if the system is unreliable, it's not very likely to be safe as well. Is care safe today? And I will explain that. But clearly, you can have an organisation that's been fantastic for a year, and then suddenly, next week, there can be a catastrophe, or the whole organisation could go into meltdown. This is possible. Not easy to predict. Will we be safe in the future? This is a question not very often asked. But clearly, you know, financial planning requires looking ahead. This is ordinary. But we haven't got that sort of thinking in safety. You know, people will reconfigure the cardiac services without thinking much about the safety implications. And are we responding and improving? Now, this is actually not, this started as reporting and learning, but actually it's become integration and learning. It's how do you pull this information together? So that what gives you this kind of circle of 5 domains: harm, reliability, sensitivity to operations. This is a term that I'm using for monitoring. It comes from the high reliability industries, the nuclear, the studies of aircraft carriers and so on. This idea that guys on the flight deck on an aircraft carrier are just sensitive to what's going on around them. That was the image that I wanted. Anticipation and preparedness. These are obvious again in daily life, but not so much in healthcare, and this integration. So I'm just going to walk you through exploring these. Now, the importance about this is, can you tell me when I'm going behind? Because I've got a watch on at the moment. How am I doing?
No, we're okay for a good 20 minutes.
Okay, fine. Try and do the rest in about 15 minutes. So these are domains to explore, not fixed down. So in each area, so if we take harm to start with, it's a question of what you mean by harm. Now, harm is not the list of incidents that you get or particular measures. If you look in any area, you can start to think about types of harm from the patient's side. And these are just some generic categories. Some harms are generic risks of healthcare, like infections or falling over. Others, like a surgical complication, are specific to that treatment. Then outside hospital are failures of diagnosis. And also, since Francis, we can think not just about error, but neglect. So there's all these kind of things. And again, any clinical area, the harms are slightly different. The problems of sort of very poor care, which is how I distinguish it from the sort of quality. So, for instance, if we take care of the elderly, for instance, my colleague Susie Long, who did a PhD, she's a consultant physician in care of the elderly. She did a PhD on this topic, and she taught me that, well, sure, in our care of the elderly, we have these errors and adverse events. We have the usual sort of things that happen to any patients. But she said there's a lot of other things happen to older people in hospital which are just not picked up at all in the classic kind of methods of looking at safety. So falls and pressure sores we've got now in the safety thermometer and so on. But delirium, if you're not treated properly in hospital, you can acquire delirium. You can acquire depression, malnutrition, incontinence from being in hospital if the care is poor. I mean, people know this, but it's not in the safety kind of arena enough. And yet it's a classic harm that comes. And then again, this is not picked up anywhere in most of our information. So these are a whole lot of new things which Susie was arguing that, you know, we've got to bring into our thinking when we're thinking about safety. And wherever you go, if you go to obstetrics, they have another list of things that, particularly things that are dangerous and can go wrong. And what we need, we haven't got there yet, is a kind of landscape of harm. Now, I suppose this is a bit overwhelming, but it's perfectly possible to put this together, or at least think what each area is going to prioritise and think about. Now, let's look at reliability. Not everything can be reliable. The whole NHS is riddled with standards of what should and shouldn't be happening. And I think I could enlarge on this for some time. But within each area, it is possible to decide on certain things that are absolutely critical. And one of the importance of checklists and stuff like and things like this is in a way that they prioritise what's important. And there's a sea of procedures that should be being followed. Some completely trivial, some absolutely critical and fundamental. So it's a question of identifying those processes where you really need to be reliable. And let's just take some examples from some Health Foundation work. I don't know if you've seen this. They did a study on called the WISER study. My colleagues at Imperial did it, Brian E. Dean Franklin. And they looked at some basic stuff. Are the information there for the clinicians trying to make a decision? Is equipment there in the operating theatre? Let's give you some examples of things they found. So this is a picture of a doctor, and this is a standard list of information that they might need, or if you were going to see somebody, where I was going, that you might hope they had available to them. And how often do they have it? As you can see, about sort of 20% of the time, or 15% of the time, they don't have all the information. Now, most of these hospitals have a coffee shop downstairs, and if you go into the coffee shop, they are pretty well tuned up, and they have all the stuff there, and they don't operate at these kind of margins. Now, a lot of the time this doesn't matter too much, and most importantly, the clinicians are very adept at working around it. They're always working around things. But for us as patients, this is far from ideal. Here's another example that may seem... sorry, I'm probably jumping the slides. Oh, okay, there we are. Equipment in the operating theatre. You might think it not be very sensible to start an operation unless you had all the equipment there. I mean, you wouldn't go on holiday without checking you had everything. But this is routine. These are figures from several organisations, several hundred operations, and as you can see, 15-20% of the time operations start without the equipment or being there, or bits of it faulty or something. Now, I don't mean that people are reckless, it's just what they put up with. And interestingly, of course, organisations are very different in the level to which they tolerate this. But these very fundamental things are things very important to understand at board level. And I've given a similar talk to this about this in mental health and other settings, and they it's the similar problems they have, or are different. So here's a surgeon. It's a very classic quote. They always need it. Time and again, it's not there. So they work around it. So when you see this kind of things, you can begin to see why monitoring what's going on day to day has an importance that we don't always think about, and it's not at all in our thinking about safety at the moment. So this is the monitoring. I'm using the term sensitive to operations. Some people like, some people don't. I don't mind what people call it, but let me try and give you a sense of what I meant by it. And let me also say that I'm not saying to you that this is a kind of done and dusted. This is a proposal that this is important. And at the moment, the Health Foundation are doing a big program to find out how important this really is and whether this is a valid framework. And people, boards and others are testing it out. But the image is, if the safety is actually very fluid, and again, you know this from driving a car or running an organisation, you've got to watch things and keep an eye on stuff. And my image for this, for clinicians, is if somebody is actually at the bedside of a patient, they're sick, and they're watching them, and they're watching for changes, and they're saying, what are the new threats? Is the temperature going up and down? What are the levels? And they're just constantly monitoring and seeing what's going on. And it's my image of this is an organisational equivalent. So if a nurse is running a ward, they've got to know, are we short-staffed? Is we've got a trauma patient coming in that's going to take all our attention off these people over here? What's the team like today? Are they all in a bad mood and are kind of fighting with each other and moaning in the corner when they should be getting on with things? Have we got problems with pharmacy? Are the drugs not come up? There's constant threats to safety through the movement of all these things. And that's what that's trying to get at. Now, this is partly, you might say, well, can we teach this? I don't know is the answer to that. Perhaps to some extent. But what you can do is, rather than assuming that things will work okay, you can make a different assumption, which Jim Reason calls chronic unease, if you like. And you can build things into the procedures which allow you to constantly stop and reflect and check on what's happening. Because mostly healthcare works just by carrying on. Because things go wrong all the time, it's routine, and people just get on to the next thing. But you can build things in. The safety walkarounds where executives will get down on the floor and actually talk about these things. Briefings, handovers, having people specifically designated to watch and so on. Handovers and briefings and ward meetings on the ward to actually discuss things are particularly critical, I think. Or in whatever setting, whether you're a community mental health team or a primary care practice, you can do this. So that's just a flavour of what that's about. Anticipation. This has importance in many settings. Looking ahead, I mean, some people say, well, it's like monitoring, but no, I mean a longer timescale. Monitoring is a day or a week or something. It's what sort of stuff that's happening now. But nevertheless, there's not a sharp division. It's interesting to look at the WHO surgical safety checklist, which looks mostly, people think about it as just a list of stuff to be checked. But actually part of it is standing there with a group and thinking ahead deliberately to this patient, are we going to get bleeding, are we going to get equipment problems, and also to the list for the day and maybe further ahead. And again, you can build this in. Risk registers, if they were used properly. I heard somebody yesterday called them just a sort of depository for anxiety or some such phrase. It was wonderful. But they could be used for actually predicting risk. And if you think about staffing levels, locums, use of locums and things, it's possible to predict this several months ahead. We're a long way from thinking this ahead, but we could start to build this in. Safety cases in industry are a formal way of trying to think about safety and risk ahead of putting major implementations in. And certainly nurse staffing, we know now that there's quite a lot of evidence that you can link this staffing levels to infection levels and various other things. So trying to use staffing levels to predict safety problems is definitely feasible, and it's been worked on in various places. And you can then also come to start integrating and learning. And I was going to put in a little bit about instant analysis here, but I think with the time I ought to just jump that. I can come back and talk about it if anyone wants to, about the proper use of instants, but I think I'm slightly concerned about the time, so I'm going to jump that and come to this. And just say that integration and learning, in fact, the whole report works on different levels. Board, the clinical directorate, the ward, the mental health team, the front line, whatever. So we found some nice examples of people who had built this, what we were calling integration, into their work. So in Great Ormond Street in the paediatric services, some of the teams had started to have weekly meeting where they reviewed all their safety information and they pulled it together as a group. And some of this was quantitative stuff, they had the numbers, but also it was soft stuff, conversations they had in the corridor, from the ward rounds, from the briefings that morning, and so on. And they brought it together and they used it to reflect on what they were doing. It was a formal part of the week. And probably in the days of yore, when they had sort of more formal ward rounds, this was all happening. I'm not pretending this is new stuff. People have always done this kind of thing. It's a question of trying to build it into these organisations. And you can find examples of organisations, this is Intermountain Healthcare, which have really sophisticated safety and quality information systems. 80 metrics, all collected, huge suite of staff actually measuring it, monitoring it, pumping out reports so that everybody in the organisation knows what's going on. We're a long way from that, but it's obviously possible. So that's the basic framework. And the other, just to finish on 2 or 3 other things. The other thing we did was that we had to write a concluding chapter, and having sort of finished the thing, really, and got to the end of it, we're faced with the idea of having to write some sort of conclusion. You can't just write the end. But again, it's fantastically boring just to write what you already written, you know, again in a shorter form, and it just seemed too tedious for words and also for the readers. So actually what we did was trying to pull together the things that we felt we'd learned and were particularly critical. And we put in, which I won't go through them all, at the back of the report there's 10 principles that we put forward, if you like. And I mean, these are a couple of them. One is that the monitoring, the extension into monitoring day to day, and to think about that as a core activity is very important. Because at the moment, if you're a nurse or a doctor, and supposing you're just wandering around the place, or you're a board member, is this a useful activity? Wandering around chatting to people, rather than being at your post, as it were, and so on? Well, I would say yes. And probably we need to do quite a lot more of that, and we'd be safer if people were given space to do this. And part of the reason of giving this a name is trying to dignify it and say this is a safety critical activity. This isn't just wandering around chatting. And the other one is that comes up a lot, perhaps not so much now, that the single measure of safety is a fantasy. I think that needs to be understood. It's absolutely bonkers to think that one measure. Where I used to work, when you went in, they had a screen that, you know, that these screens that hospitals have that say how wonderful everything is, you know. And there's usually some dirty trolley parked underneath, but giving the whole thing away. But one of the things it said was, one of the screens was, we are one of the safest hospitals in the country. Our standardised mortality is the lowest in southern England, or third, or something like that. As if that single piece of information told you the entire hospital was safe. Extraordinary. I won't go through these. So the organisers asked me to leave you with a terrible question to ask you, like for, I don't know, for the examination or whatever you're required to do. So my question is very simple. Is your organisation safe? And more importantly, how would you know? And but I have also kindly put in a few, I've just summarised the questions, but I come back to this. The questions that we arrived at are those questions that now I think I would be asking myself. And I stress again, just to finish, that I do think it's the continual questioning that's important, even if it drives everybody mad. And obviously there's one can't do everything, so one has to decide what to look at. But I hope that in this report, if you or somebody in your organisation has a look through it, there's a direction and a way now of getting started. And I think it's pretty clear now that you can investigate relatively easy in these different areas. And I hope that you'll find a lot out if you took these approaches. Anyway,
Great.
That's my response to the Berwick Challenge, and thank you very much.